I'd like to move now, please, to item 6 on the agenda, which is our normal two-part paper, dealing first of all with NHS England corporate performance and then NHS performance. I'd like to invite Karen to introduce part 1, please.
Thank you, Malcolm. So this is to provide the board with some assurance around how NHS England is doing on its business plan priorities for 15-16. We've been putting in place a series of stock takes throughout the year and culminating in a stock take at the end of the year to confirm both that those programmes were on track to deliver the targets for 15-16 as our business plan commitments. And secondly, importantly, since our business plan for 16-17, which we've recently published, builds on those 10 priorities so that we'll be taking those into this financial year and probably the next very substantially, that those stock takes have assured us that they are on track to continue to develop and deliver against our priorities for the next year, so that ultimately they will play their part in the 5-year forward view targets that we are all very keen to deliver. So this just provides you with that assurance. We haven't provided you with all the detail on all of the programmes, but just pulled out to where we are not as green as we are on the rest of them. I wasn't going to say very much more on that. The two others, child health, child protection information and care.data, again, they're not individually priorities, but they're part of our national portfolio of programmes that we report against. So happy to take any questions on those, but it's largely to provide you with that assurance that we are well set up for the delivery of this coming year.
Okay, let's take up Karen's invitation for questions, comments, cross-examinations.
You'll be aware, Malcolm, that the Audit Committee has been through the portfolio with Karen, and I would observe that the degree of central programme management oversight and control has stepped up materially in the last 12 months.
Thank you, David. Right, then thank you. Maybe move on to part 2. Richard.
Thank you, Chairman. Board members have read the performance report for March, which is within our packs. March, of course, is also the final year of the business year, final month of the business year for the NHS. So it's a good time to reflect on the whole year, as well as just the last month and last few months. So in terms of the whole year, firstly, I'd just like to talk about A&E performance and 18-week performance. Simon referred to this in his introduction. In both cases over the whole year, we've still delivered well over 90% of patients, have been delivered within the targets concerned. That's a 4-hour wait for A&E and 18-week wait, obviously, for the elective side of our work. If I can just take A&E first, though, although we've delivered 91.9% for the year end, it has been quite challenging in the last 3 months, and we have seen performance levels below 90%, which is not something that we're pleased with, and we're urgently trying to address that, looking at the root causes of that deterioration and to put them right. It is worth saying, though, whilst there have been workload increases that have contributed to that, they're broadly within the parameters we would have planned for, and the deterioration of performance isn't overall. So 20 systems, for example, have been responsible for 50% of the deterioration on A&E performance. So it's important that we target those areas that are particularly struggling and understand that many parts of the system is operating fairly well. I think another point we need to make is that even though the headline performance has deteriorated, evidence around operational pressures and severe long waits show that they've been very few this winter. So in other words, we're performing better in terms of the extremes, but the average performance has drifted out. One way of describing that is for every 10% deterioration against the targets, it's about 20 minutes additional wait for a patient in A&E. And that's what we're dealing with. We're dealing with a flow problem that needs to be brought closer together with shorter waiting times, but also making sure that we can treat people safely and we can avoid any extremely long waits. And I think that the latter of those has been achieved successfully throughout the winter. On the 18-week waiting times. At the end of March, we had about 3.5 million people waiting, and only 8.5% of those had waited over 18 weeks. So again, the vast majority of patients have been seen well within the 18-week target. And again, similar to the A&E position, 20 trusts are responsible for about 1.7% of the gap. So in other words, if those 20 trusts achieved the target, the overall England performance would be 1.7% higher. So for both A&E and RTT, we have a mixed picture. The overall performance is poor, but we've got some targeted areas where we really need to improve fast, as well as seeing general improvements across the board. In terms of some better news, on cancer, the 62-day cancer weight in March, we achieved 83.8%, which is 3% higher than the figure we achieved in February. So we're making progress on the cancer weights. In some other areas, we've made some excellent progress across the year, particularly in the areas of mental health. So the improving access to psychological therapies services, for example, we set ourselves a target of a 15% population coverage rate on that. Our expectation is that that would be the level of population that need those therapies, and we've achieved a 16.6% coverage rate across the year. So we are getting access to those services that are getting to the patients who need them. We set ourselves a target of a 50% recovery rate, and we're well on track for that, achieving 47.9% towards the end of the year, and it continues to improve month on month. And finally, we set ourselves a target that 75% of patients would be seen within 6 weeks, not 18 weeks for this service, but 6 weeks for this service, and we achieved 84.3%. So some good results in the psychological therapies services. And looking finally at dementia services, we set ourselves a target that we would diagnose 2/3 of all of the whole population that's expected to have dementia, and we achieved that with a 67.5% performance by the year end. So overall, it is a mixed picture. Some good performance in the mental health arena, some challenging performances in the acute side of things. Overall for the year, there's been strong performance in terms of the 9 out of 10 patients seen, and I think we've also got to give credit to all of our staff, both inside and outside of hospitals, for achieving that, set against a broad increase in workload of around 2% on the emergency side and about 3% on the waiting list side. But that's a summary of the report, Chairman. Happy to take any questions.
Well, thank you, Richard. I think the access requirements of the NHS Constitution are amongst the most demanding in the world for an entire population. I mean, other systems have insured groups for whom there are better access requirements. But what will concern everybody, I think, is the drift away from observance of those, almost as if non-observance is the new normal. Just taking A&E, for example, there are still some trusts who are meeting the 95% requirement of the Constitution. Are there things that are being transferred in terms of knowledge and learning from how they organise their patient flow and their work and their staff, which through the UEC review or elsewhere are being transmitted and being used in a mentoring and supportive way for other trusts that are still struggling?
So I think the answer to that is yes, but we need to move faster. The whole purpose of the Urgent Emergency Care Review is we knew that without changes to the way we manage urgent emergency care, the demographic pressures that we're facing would bring problems that we're experiencing. So the best systems have adopted some of the good practice identified in the review. Some have got a way to go to achieve that. And one of the reasons we've been under pressure in the last 2 or 3 months is some predictable things have happened. We've had late onset flu, so that's created more bed pressures. In terms of bed capacity itself, whereas in previous years we just would have opened more beds to absorb the pressures, it's less possible to do that now for a couple of reasons. One is workforce pressures, and secondly, it's not right just to open extra beds if you haven't got the right safety in there, the right number of nurses per patient. So those things have been difficult. And finally, there have been pressures in relation to discharge, particularly in the social care end, where there's been a 34% increase in discharge delays waiting for social care. So all of those things are risks. The best organisations manage those well because they've adopted new processes and reformed. Many organisations have yet to do it. So the challenge for us is to bring forward many of the aspects of the Urgent Emergency Care Review, share the good practice of those who are achieving successfully, and embed that across the board. And that's really the key to us turning performance around and making the improvements we need to.
And increasingly in close partnership with NHSI.
Absolutely.
Yeah. Can I invite any other questions. Michelle.
Thank you, Richard. A really clear explanation of some of the causes and the possible solutions. Could you tell us whether you think some of the deteriorating performance is a trend or whether it will get better by the end of the year?
Well, we're clearly observing a trend in both A&E performance and RTT, 18-week performance, and this has been happening for around 2 years. So, without wanting to repeat the answer to the previous question, we knew there was going to be more pressure, and hence the need to make changes we need to make, and we really need to accelerate those changes now. There are two, again, as I described in the overall report, we need two sets of tactics really. One is to bring rapid support to those systems that are struggling the most, and it is a relatively small number across England. There are 170 Type 1 A&Es in England, and the 20 we've described causing 50% of the deterioration are quite a small percentage of the 170. So working with NHS Improvement, we're really doing our best to bring support, a support offer of resource. We have an emergency care improvement programme, and we're expanding its coverage from 25 to 40 systems, and that would cover the 20 we're talking about. So we really need to bring resource from the best practices across England, helping those systems to see and adopt that practice. But then, of course, we've got to make sure that that is actually taken up and followed through.
So you have confidence the numbers will improve?
As long as we do what we've planned to do, that should happen. It's a natural consequence. We bring the improvement techniques, people adopt them, and we've certainly seen from the evidence of the best that can bring results.
David, I just wonder, Simon, this is from the majority of the citizens' perspective, A&E performance, RTT performance, we've done well on other things, let's be clear. It's not a complete bad news story, but on the big things, there is real concern. And therefore, I wonder whether you could sort of share with the board maybe some of the thinking that you've had with Jim on how we change this trend line and get to an improving position, recognising this is not going to change overnight.
Yeah, so I think what Jim would say is that the principal purpose of NHS Improvement is what it says on the tin, i.e. improvement, and so looking out to next March 17, their expectation is that the NHS provider sector will be in a better position on those performance measures than it was March 16, and that's part of what we expect to see, given that we have funded activity growth through the commissioning system and the contracting round for this coming year, and made available the 1.8 billion on the sustainability fund, and there is this specific set of trajectories that are being agreed with individual organisations based on what is a realistic improvement level for them individually.
Right. I think we're done. Richard, Karen, thank you very much for that.